Today we're going to discuss the scoliotic patient as it applies to the Cox flexion distraction procedures. There's basically three applications. One is a scoliotic patient with a disc lesion. Two is a scoliotic patient without a disc lesion. And three is a scoliotic patient that you're actually treating for either stabilization or possibly reduction of the scoliosis. So the first one, we'll just say that we'll say this is Shannon's x-rays right there, and that's a standard configuration for an S-shaped thoracolumbar scoliosis. Lumbar spine is deviated laterally to the left. We call that a levoscoliosis. The thoracic spine is laterally deviated to the right, and that's a dextroscoliosis. Okay, so if Shannon came into the office and possibly didn't even know she had a scoliosis, some do, some don't, but her main presentation was severe acute back pain with pain extending down the back of the right leg all the way to the foot. So we'll just say she has a true radicular component. Her main concern is she's in a lot of pain, and she would like you to help her with that and help her get some relief of that condition. Okay, so in examining her, you discover that it is disc related, and you want to use Cox procedure. You x-ray her and notice that she has scoliosis. So the problem that we have here is that her vertebral end plates are not level. Okay, the vertebral end plates are all sitting on angles, and when we distract, we're going to be much more effective if the vertebral end plates are level. But in her case, we've got they're wedged open on the left side. Okay, so that's easily correctable. So we're gonna give her a scoliosis. Just relax forward. All right, so let's say that is her normal configuration, and again, that matches the X-ray. Again, we mentioned that we get much more effective distraction if we can level the vertebral end plates. That way we get even distraction going throughout the fibers of that disc, as opposed to uneven distraction, which has the potential to create complications, which we'll discuss in lecture. So what we're going to do to correct this, it's really simple. We're going to release the lateral flexion lever, and we're going to eyeball her lower back, the lumbar musculature, the erector spinae, and we're going to reduce that scoliosis, and it'll get to the point where you see those erector spinae muscles basically just pop into place, and then you're going to lock the lateral flexion lever. Okay, and so all we've done is we've taken measures to reduce that scoliosis and level off those vertebral end plates, and then we can go ahead and just use our standard protocol 1 on whichever vertebrae may be involved, whether it's L5 or L4. Those are typically the two most common levels. We would just do your standard protocol 1. It's just that the table looks a little misconfigured, but if it was, let's say it was an L4, we would get over the patient just like we would for standard protocol 1, find the barrier of elastic resistance, and do your 5 4-second pumps. You do that 3 times. The only thing that we've done is we've leveled the vertebral end plates. We're going to get a lot more effective distraction to that disc by doing that. So that's the first application for a scoliosis. All right. The second application is when you have an acute lumbar spine disorder, no radicular component. And the fact that there's no radicular component means that she would be placed into protocol 2 for reestablishment of physiologic ranges of movement of the vertebral segments. Okay, so let's say she came in with an acute lumbar spine disorder. We discerned that L4 was the offending vertebrae. There was no radicular component, so we wanted to go in and recondition or mobilize L4 using Cox protocol 2. We basically release the flexion lever. It's already released. Release the lateral flexion lever and get a contact on L4, and do your 10 2-second pumps in flexion. Okay, all right. Now is lateral flexion, And the problem that we run into is we really don't want to laterally flex this patient into the concavity of their curve with the potential of increasing the curvature. Okay, so for someone with a scoliotic configuration with protocol 2, we only distract into the convexity of the curve, not into the concavity of the curve. So when we get to lateral flexion, you find that barrier of elastic resistance, and you only laterally flex to the left. Same thing for circumduction. Standard protocol 2 is we do circumduction to the left and to the right, but with a scoliotic curve, we would not want to take her to the right because that has the potential of increasing that curvature. So when we get to circumduction, we're only going to circumduct to the left in this particular case. Okay? And then extension would be standard, normal protocol 2, where you change your line of drive to 2/3 P to A and 1/3 I to S. So the thing to consider and apply in a case like this, again, this is a lumbar spine disorder without a radicular component where we're going to do protocol 2, is that we eliminate 2 of the movements. And those 2 would be lateral flexion into the concavity and circumduction into the concavity. And otherwise, you just use standard protocol 2 procedure. Okay. The third one is for an actual scoliosis, where you might have an adolescent who comes in, maybe they were screened at school, and the mom brings the child in and says the nurse believes the child has a scoliosis, and we wanted you to take a look at it. And you examine the child, you find that there looks like there is evidence of scoliosis. You take an x-ray, and that's the child's x-ray right there. So we want to see if we can do something to stabilize it, keep it from progressing, maybe even reverse it. So in a case like this, we're going to do protocol 2, but we're going to do it more on a global basis. We're not just going to pick a particular segment. We're actually going to distract, in this case, L5 all the way to T11. And we're also going to follow that same principle that we just discussed. We're not going to do lateral flexion or circumduction into the concavity. So in this particular case, I'll tell you what I'm going to do. I'm going to, for learning purposes, I'm going to reverse your scoliosis. The camera's this way. Okay. Okay, so I like to stay on the convexity of the curve, because that way I can put a little counter pressure into it. Okay, so in this particular case, we would start at L5. We would do 10 flexions at L5. We'd go to L4. We'd do 10 flexions. L3, L2, L1, T12, T11. Right? We want to get the whole span of that scoliosis. All right, we're now ready for lateral flexion. And so what we're going to do is we're going to start at L5. We're going to find that barrier of elastic resistance, and we're going to do 10 lateral flexions to the right. Move up to L4, 10 lateral flexions to the right. Move up to L3, 10 lateral flexions. L2, L1, T12, T11. We're not going to do lateral flexions to the other side. So in other words, we're only going to do half of the lateral flexions, making sure that we do not go into the concavity of the curve. All right, circumductions, we're going to drop back down. We're going to do, start at L5, we're going to do 5 circumductions to the right at L5. 10 circumductions to the right at L5, 10 circumductions to the right at L4, 10 circumductions to the right at L3, L2, L1, so on and so forth. We're then going to move back down and do our extensions. Start at L5. We're going to do 10 extensions, L4, 10 extensions, L3, 10 extensions, so on and so forth. So when your goal is to see if you can stabilize or reduce a scoliotic curve, you're going to follow the protocol 2 guidelines, but you're going to do it more in a global fashion, and you're going to eliminate lateral flexion and circumduction into the direction of the concavity. And this can be an effective way again, at either stabilizing or potentially reducing the scoliotic curve. And that's an overview of scoliosis.